Hi everyone, welcome back to part 3 of our tutorial series on blood gas analysis. I'm joined by Graeme again. How you going, Graeme? You have a good weekend?
Oh, great weekend, Roger.
Yep.
A couple of parties, caught up with family. Nice to be back at work though.
Okay, so hopefully your brain's in gear, because I'm going to put you on the spot a little bit, Graeme, and we're going to go through the 4 primary acid-base disorders. We did briefly touch on them in the last tutorial, if I remember rightly, although it has been a few days since we recorded that one. So here they are: respiratory acidosis, respiratory alkalosis, metabolic acidosis, and metabolic alkalosis. So, all right, we're going to jump straight into it with an example, and then we're going to talk about respiratory acidosis in more detail. But this is a blood gas of someone with a respiratory acidosis. Do you want to just run through it using the 5 steps that we mentioned in the last tutorial?
So I'm trying to remember the 5 steps,
Yep,
but I think
so
the first one is how does the patient look
I can tell you the
clinically?
step, and so well, actually, we're not going to. We'll do some case examples in the next tutorial. But for this one here, we're just going to talk about the disorder itself. So we're not going to talk about a patient. So we won't go into all the clinical details, if that's all right.
Yep.
So 5 steps. What's the pH?
So the pH is low, which is an acidemia.
Yep. And then what is the CO2?
The CO2 is high, which is a acidosis or a respiratory acidosis.
Yep. What's the bicarbonate?
The bicarbonate is high.
Yep.
So that's...
Yep. So that's, what is it? Alkalosis.
It's a metabolic... Oh, sorry, it's an alkalosis.
Yeah.
Yep.
So, but we don't know which is the primary or secondary, do we? So
That's
now
correct.
we've got to figure that out. We can sort of tell, or we can actually, from those 3 things we discussed, that the primary problem is an acidemia. And so the pattern that we've just described is that it's probably primarily a respiratory acidemia, or acidosis causing acidemia, with a little bit of a metabolic alkalemia to partially compensate.
Yes.
That's what it looks like, isn't it?
It
And
does.
that's what it is,
It
because
is.
we're just trying to keep it simple at this stage. And then the 5th part of the assessment is to check for compensation, which we'll do a little bit further down, and in a couple of slides we'll talk about the different rules, which, by the way, no one should be expected to remember. You should always just look them up. In this day and age with Google and mobile phones and things, it's pretty easy to look them up each time. Let's just talk about what sort of things can cause a respiratory acidosis. So it's good to just, when you recognise a respiratory acidosis, then to think to yourself, what's going on with the patient, what's the cause, what could be causing this, and so what are the most common causes of respiratory acidosis?
So
right?
common causes of respiratory acidosis that we see are sometimes the result of our work. Medications which cause hypoventilation, including administration of opioid medications. That
Yep.
would probably be one of the commonest causes.
So I guess what we're talking about here, first of all, this is by far and away probably the huge majority of all patients who have respiratory acidosis, is just going back to the physiology. At rest, we have a sort of fixed metabolic rate, and so we make a certain amount of carbon dioxide every minute. And the most common reason why our CO2 levels rise is that we are not breathing fast enough or deep enough. Our minute ventilation or our overall ventilation is not adequate to remove that fixed amount of carbon dioxide production, so our CO2 goes up. So so we'll just talk anything that interferes with the any respiratory diseases that interfere with ventilation, basically.
Yep. So any other respiratory diseases, including asthma, potentially with infections in the chest.
Yep, pneumonia.
Pneumonia, or problems like airway obstruction, for example, from obstructive sleep apnea.
Yep. So common things that we would see in our hospital setting would be in the HDU and recovery and in theatre is over sedation with drugs and sleep apnea, like you've mentioned. And then I guess you got to think of those other medical causes, chronic conditions.
Yes.
Now the small print. So there are other reasons why you could have a high CO2. You could be making too much CO2.
Yes.
That's pretty rare, isn't it? But those what are the sort of things that you'd see, and usually they're quite sort of dramatic and obvious.
Sometimes metabolic conditions, malignant hyperthermia. It's an anaesthetic-specific condition where some anaesthetic agents trigger excess production of or excess metabolic activity. Conditions like hyperthyroidism, catecholamine excess in conditions like pheochromocytoma, or even the serotonergic syndrome.
Fevers and sepsis and those sorts of things.
Yes.
So my understanding is that even in those when those conditions exist, if people have normal lungs and normal level of consciousness, they should still maintain a relatively normal PCO2 level. Just think of someone who's running a marathon or performing vigorous exercise. They make a lot of CO2, but they just breathe harder, and their CO2, if you did blood gas on them, is actually pretty normal. So these patients are usually sick and they're making too much CO2, but they must usually in general have something wrong with their respiratory process, their control of respiration as well. So usually a decreased level of consciousness or something like that. And then increased intake of CO2. This is real fine print.
We see it very often in our work in operating theatres with CO2 being the gas that's used for things like laparoscopic or
that's right.
Laparoscopic surgery, insufflation, yes.
Yep, so the surgeons pump our patients in theatre full of CO2, and of course patients aren't conscious, so they can't increase their breathing rate. They're just on a ventilator, which we have set at a certain rate. So unless we change the ventilator rates, then their CO2 levels will go up. And also you can have some unusual situations like problems with your anaesthetic machines or your ventilators if you're in an ICU setting. Situation where the CO2 absorbers aren't working, or the circuit perhaps is they've got a faulty valve and they're rebreathing, that sort of thing. So that's the sort of thing you've got to keep your eye out for.
Inadequate fresh gas flow into a Hudson mask, for example.
Correct, yeah. And
rebreathing.
And sometimes we use this for people who have respiratory alkalosis, getting them to breathe into a paper bag, that sort of thing. And the other thing that I mentioned before when we were talking about this before we started was Apollo 13. Anyone watch that movie?
It's a great movie.
Yep, so I think one of the problems they had was that with all their equipment failures on the flight, is that they started getting very high levels of CO2 in the spacecraft, and they had to try and scrub that out. So obviously that was going to cause, and so they all had respiratory acidosis because they were breathing in high levels of CO2 in the atmosphere.
And that all happened on the dark side of the moon.
It did,
as I recall.
That's right, yeah. Okay, so now we're going to talk about compensation. This is a little bit harder to get your head around sometimes. So basically, you've got to remember the physiology. So this equation here that we've got up, we introduced it last tutorial, I think. So you've got to remember that CO2 on the left-hand side here combines with water. So if you increase the amount of CO2 on that side of the equation, that'll push molecules across to the right-hand side. So if you put lots of CO2 in, you will also increase the bicarbonate, because these molecules will combine with water to make carbonic acid and then make more bicarbonate. So this is a way of assessing the bicarbonate level to see if it's gone up purely because you're just making a little bit more bicarbonate from the extra CO2 you hang on to. And the rule is 1 to 10. So if the bicarbonate increases, the bicarbonate should increase by 1 millimole per litre for each 10 millimetres of mercury in CO2. Let's go back and have a quick look.
These are called the Boston blood gas rules.
That's right. So you're not supposed to remember these. I can't remember them. Can you remember them, Graeme?
No.
You're more cleverer than I am, so I thought you might. But no, I can't remember that stuff. I always look it up. If you type Boston compensation blood gas rules into Google, you can find them, and you can just do this in your everyday practice. So let's apply this rule. So the CO2 is 70. It's 30 millimetres of mercury higher than normal. Normal being 40. So the bicarbonate should, with the 1 to 10 rule, should go up by 3. And so bicarbonate here is 27, which is 3 higher than 24, which is normal. Surprising how that's exactly right, isn't it?
Yeah, an acute respiratory acidosis.
And it's not that surprising, because I actually wrote this slide based on the Boston rule, just so that it would match perfectly. In real life, patients aren't always match the rules perfectly, but they do in PowerPoint presentations, obviously.
And they do quite often in clinical practice as well.
Yeah, so a rule of thumb, obviously there's a bit of error there, but if it's by a rule of thumb, if it was around that, then that would make you think it's a acute event. Okay, so what about what's a chronic respiratory acidosis, Graeme?
I mean, where I've seen them are patients with chronic respiratory issues, including sleep apnea.
Yep.
That would probably be the commonest times I've seen it. But then you could have it if you had chronic lung disease.
Yep, so anyone with chronic
forms.
lung disease,
Yep.
the like you say, sleep apnea and COPD or emphysema seem to be the most common encountered things in real life. So what you might find is you've got a patient who presents for surgery or comes into your hospital and has a history of, let's take an example of COPD, who's been a smoker for years and has had COPD for years and years. and you do a blood gas on them, and they have a high CO2, but they've had it for years. And when you've had it for a long time, classically sort of 3 or 4 days, but some of these people were years, then your kidney can compensate for the acidosis. So when you give someone a shot of morphine and their CO2 goes up over the next half an hour, the kidneys don't have time to change the bicarbonate level. So that's why you shouldn't see any acute changes in the bicarbonate from the kidney. But if you've had 3 or 4 days or 3 or 4 years, then you have to apply this rule, which is 4 to 10. So the bicarbonate should increase by 4 millimoles per litre for each 10 millimetre of mercury in CO2. That's a bit of a tongue twister.
It is. And I think it's almost an opportunity to predict some problems. If the patient's known to have chronic lung disease and you do even just a use and ease and the bicarb's a bit high, it's often just a marker that they may have some chronic compensation for their respiratory acidosis.
All right, so I've tried to tease that out here. So this is the sort of thing you might see. So if someone has a respiratory acidosis with a CO2 of 70, you've got both of these patients here have CO2 of 70. If it's occurred acutely, then the bicarbonate is only a little bit up, so 27, so a little bit higher than 24. And the base excess, which I can't remember, did we explain that?
We did explain it in the last tutorial.
Yeah, so that's the machine calculates what your standard base excess is. Does lots of fancy mathematical algorithms. It's basically trying to estimate what the metabolic component of the changes are for you. We won't go into that. We won't go into that in detail now because we're trying to make an example of something, but maybe we should do that a little bit later.
We may not have explained it in the last tutorial.
Yeah, okay. So base excess is the machine's way of calculating how much of the acid-base change is metabolic versus respiratory. Yep. So it does have some errors in it, and you'd have to sort of go through the detailed explanation of how it calculates that. But when you're looking at it and just assuming that it's got it right, if 0, anywhere between +2 and -2 is sort of normal. So 0 means that it thinks that the change in pH is all due to respiratory changes, not metabolic changes. So that's what you would see on the machine there.
On the left-hand side, on the acute.
Yep, under the acute setting. And on the chronic, so this patient has a high CO2, a respiratory acidosis with a PCO2 of 70 as well. You can see that because it's a chronic condition, the kidneys have had time to produce more bicarbonate, and so it's gone up to 36, and this is partially compensated. So the pH has almost come back to normal, but not completely. So it's had time to improve the pH, and you can see that the machine has calculated all these changes and given you spat out a number saying the base excess is +11. So base excess means, so a positive base excess means there's more base, so there's metabolic base, i.e. alkalosis, and a negative base excess is the opposite of a base, which is an acid. So a negative 11 would be a metabolic acidosis. Yeah. Are you confused?
No.
No, I'm not, but I think some of our listeners might be. But anyway, they can always rewind and listen again, can't they?
They can.
Or they can listen to someone who explains things better on another podcast.
Yeah. But on the right hand side, just to go over it again, you see a respiratory acidosis with metabolic compensation.
Exactly.
Yeah, and the primary problem is the respiratory acidosis, and the compensation is the metabolic alkalosis.
Yeah, compensatory metabolic alkalosis. Yeah, and you can tell which is the primary one because the patient is still acidemic. So the primary problem is the acidemia, and the compensation is a bit of alkalemia.
Yep.
Alkalosis. Right, let's move on to the next. So the opposite of a respiratory acidosis is
an acute respiratory alkalosis.
Correct.
Oh, sorry, a respiratory alkalosis.
That's right. Yeah. So we've got acute there. So acute means it's occurred suddenly. So what happens when just explain what a respiratory alkalosis is and describe what you see.
Okay. So respiratory alkalosis is a condition in which an abnormal problem affecting the respiratory system leads to an alkalosis. And with this blood gas, you see a pH which shows a high pH, which is an alkalemia.
Yep.
The PCO2 is lower than expected, which indicates an alkalosis, respiratory alkalosis. And in that blood gas, the bicarbonate is also low, which would suggest a degree of metabolic acidemia.
Yep. Now that's probably occurred just because of the that equation, the Henderson-Hasselbalch equation, where the CO2 and the bicarbonate change acutely. So
forget everything I said about metabolic compensation. It's indeed reflects the acute changes.
It is a change, though, isn't it? So, but the base excess is 0, so nothing has happened in the kidneys. The kidneys didn't have time to change things. So basically, this just looks like someone who's breathing fast and hard, and they've got rid of CO2. They've dropped the CO2 level in their bloodstream, made their pH alkalotic, and it's an acute event because the base excess hasn't changed, and the bicarbonate, if we use the rule, which we'll calculate in a minute, has only changed a small amount, which is in fitting with an acute change. What are some common causes of respiratory alkalosis?
So anxiety or hyperventilation.
Yep. That's the most common
syndrome
sort of thing we see.
associated with.
What about in obstetrics and gynae hospital? This is where we work.
In obstetrics, hormonal changes during pregnancy drive increased ventilation and do cause a respiratory alkalosis.
That's right.
However, the pH in our pregnant women is normal because of a metabolic compensation.
That's right. So it's a chronic respiratory alkalosis, isn't it? Yep. But I think we are going to talk about respiratory alkalosis, acute and chronic, at the same time. So basically, you're just breathing more. So excessive alveolar ventilation. So pregnancy, panic attacks, the classic one. People are very anxious. And there are some other things too. So hypoxia. So people who, so the usual thing that drives how much we breathe is our CO2 level. But if you go up to altitude, like Mount Everest, something like that, and your PO2 drops below sort of 50 or 60, that actually stimulates you to breathe harder as well. So a very classic finding in the blood gases from people at high altitude is that they have a respiratory alkalosis as well, which you wouldn't see at sea level. Lung pathology, aspirin poisoning, so salicylate, I'm not sure what the mechanism is for that, but salicylate seems to stimulate breathing. So all those things are the sort of things you should be thinking about. So pregnancy is the most common one we'll see in our hospital anyway, and hyperventilation as well. Pain, I should put that in as well. So I did read a little bit about during labour, for example. We don't do it very often, but if you did blood gas on someone in labour, they actually quite commonly, they already have a chronic respiratory alkalosis, but they probably have a degree of acute respiratory alkalosis, especially if they're sucking on that nitrous oxide Entinox thing. That they really go for it, and they can get quite alkalotic.
I wouldn't be surprised.
So how do we calculate the compensation? Now I forgot to change the top of the slide there, so I've written respiratory acidosis, so I'll have to go back and change that, so please ignore that. Compensation respiratory alkalosis. So acute, remember the equation, CO2 and water going to bicarbonate, carbonic acid and bicarbonate hydrogen on the other side. You put lots on one side, it'll push everything across and create more on the other side as well. So the 2 to 10 rule for acute changes, so the bicarbonate should decrease by 2 millimoles for every 10 millimetre of mercury. Look it up, don't memorise it. So the CO2 has gone down, so remember 40 is about what you should use as normal, so it's gone down 15, so it should go down 2 for every 10, so it should go down 3, and look at that, it's gone down 3. Oh, I wonder if someone designed that on purpose. And chronic, 5 to 10, so the bicarbonate should increase. I've written increase there too, I forgot, I've done a real hash of these slides, haven't I? So it should decrease by 5, yeah. So that's what you would. So basically, that's what you see in pregnancy. It should pretty much almost bring it. So the CO2 goes from 40 down to sort of low 30s.
32, yes.
So the bicarbonate should go down by about 4 or 5.
It
probably,
does, from about 24 to about 20.
Yeah, that's right. So it doesn't go down like by 10 because the CO2 goes from 40 down to like 32, 33. So it should go down by 3 or 4, and that is about right. So a normal bicarbonate in pregnancy is around 20, 21, I think.
Yes.
Here's some examples. An acute one, panic attack, and a chronic one, high altitude. So normally these people, they climb up to high altitude and spend a lot of time acclimatising and getting used to it, and so their kidneys will have a chance to compensate. And should we go through those, or should we move on? the listeners could pause the viewers could pause and have a look at that and apply the rules themselves, couldn't they?
They could. I think that's a good idea.
So just really briefly, as you can see, the acute one, the patient is much more alkalotic because they haven't had time to compensate. The bicarbonate is a bit higher. The chronic one, the pH is almost back. The chronic one, the pH is almost back to normal, and the bicarbonate's a lot lower because it's had time. The kidneys have had time to compensate. And you might notice in my example there, the PO2 is quite low. That's because they're really high, not because they have lung disease. So if you're up at Everest Base Camp or higher, then you'll have a low PO2. That's the reason why they're breathing hard, is because they're a bit hypoxic. All right, take a deep breath. We're on to metabolic acidosis. So probably the most important conditions that we see, or most common things that we'll see in everyday clinical practice, is respiratory acidosis and metabolic acidosis. Would you agree? Alkalosis is less common than acidosis.
I mean, I think the only difference is that we work in an obstetric hospital, and so there's all those patients with fully compensated.
That's true.
Respiratory alkalosis.
True, but often they're pretty well, and we don't need to do a blood gas on them. So it's only when something happens to someone that we take a blood gas, isn't it? It's usually an acidosis. That patients do get alkalosis, so we will. Let's move on.
Yes.
So metabolic acidosis. Quickly go through it. We're getting the hang of it now, I think. So we can probably get you. You can give us the quick description there.
So too much metabolic acid.
Yep.
And then looking at this blood gas, the pH is low, suggesting an acidemia. The PCO2 is low, suggesting a respiratory alkalosis.
Yep.
The bicarb is low, suggesting a metabolic acidosis. And the base excess is very negative, suggestive that this is a primary metabolic acidosis.
Yep, that's right.
With some respiratory compensation, but it's incomplete.
So it's almost certainly the primary condition is acidosis because the pH is so acidemic, and a low CO2 actually makes you alkalotic, doesn't it? Mm-hmm. So that's probably just the compensation.
Yes.
So when you get really acidotic, your body's going, Jesus, we've got too many hydrogen ions around. Let's get rid of all the CO2 to try and bring it back closer to normal.
Yeah. You can almost see this patient huffing and puffing.
Yep, that's
breathing
right.
deeply and breathing quickly.
Yep. So
to try to compensate.
So the classic description, I don't know who Kussmaul is, but if you've ever heard the description Kussmaul's respiration, so I remember seeing a few patients like this in the emergency department. Saw a patient with DKA when I came on one day, working in the emergency department in Armdale 15 years ago, and he was sitting in the corner going, just sighing away really heavily, and I thought, Jesus, something's wrong with that guy. And they don't look like they're short of breath, but they are breathing a lot. It's hard to describe, but they don't look like they're having trouble breathing. They just look like they're breathing like someone who's running or exercising, but they're not. They're just sitting there.
That's right. Their work of breathing is increased.
It's quite when you see it, it's quite an obvious thing, and that should really trigger you to think, I wonder if that guy's acidotic, guy or gal. Sorry. So the compensation. So once again, this is the rule. Just need to look it up.
I think just think about this particular equation starting at the right-hand side of the equation, where the metabolic acid is being added into the system.
Yep.
And causing some of the changes in the concentrate or the partial pressure of CO2 on the left-hand side of the equation.
Yep. So this is just. So the compensation, now you don't have an acute or chronic here because the CO2 or the respiratory changes don't take time. So the kidney takes time to adjust to things. So when you've got a respiratory problem and you have to change your metabolic pH state to try and compensate for a respiratory change, that you can either not have time, and then in which case it's just an acute change, or you can have, if you have 3 or 4 days or longer, you can have a chronic rule. So the rules for compensation in respiratory conditions are acute and chronic, but in metabolic ones, it's just one rule because you can change your breathing within a few minutes, and so this is the only rule you have to know, isn't it?
That is correct.
It's either appropriate compensation or not.
It's not. Yeah.
So because the chemoreceptors, etc., in your brain and your carotids and things will detect the change in pH and change your breathing relatively quickly within seconds. So this is the number you should expect. So if you've got so the expected CO2, if you've got normal lungs and a normal response, should be 1.5 of the actual bicarbonate plus 8. Now there's various ones around. You can actually see variations of this. These are all just rough and ready. But this is the one that I got from anesthesiamcq.com. It's a good way of just checking. Shall we do it, you reckon?
Yes.
we'll go back and do it. So can you remember that? 1.5 times actual. So let's go back.
Okay.
So here we go. So
Metabolic acidosis. We've got a PCO2 which we expect to be 1.5 times the bicarb concentration.
So 12, 1.5 times is 18.
18, yeah. Plus 8
is...
Oh, my goodness.
20, plus 8 is
26.
26, and the CO2 is 24. So that's about right, isn't it?
It is, plus or minus 2.
Yep, so this person has appropriate response. So if they were really drowsy from morphine or had pneumonia or something like that, they might not be able to mount an appropriate response, but this patient has.
Yes.
So this patient probably doesn't have any problems with their brain or their lungs.
No.
They just have an acute metabolic acidosis. For example, someone with DKA or
Absolutely.
something like that. So that's good. All right, what are the causes of metabolic acidosis? Now, this is quite a large, very broad topic. There's two sort of ways. Usually what people do is they break it down into two groups. What are the two groups? I'll put you on the spot here, Graeme.
I can't remember, but I think it might be lactic acidosis or non-lactic acidosis.
Even before that, so usually what you do is you calculate the anion gap.
Oh, yes, that's right. High or normal anion gap.
Yeah,
metabolic acidosis.
So there's a high anion gap. Some people call that HAGMA, high anion gap metabolic acidosis, and then normal anion gap metabolic acidosis, or actually hyperchloremic acidosis, because the anion is the chloride.
Right, yes.
So you have a high chloride level when you look at the results. So the normal anion gap, because the range is 8 to 16 millimeters mercury, so there's a wide range, and that's because there's using so many different things to calculate this, that there's a wide range of error in each of these things that you calculate. So the error from all three measurements all adds up. So you do get quite a wide gap.
And
so this is quite an important thing to know how to do, isn't it? To calculate the anion gap.
It is, and it's just...
You do need to know this.
It's just reflecting the positively charged and the negatively charged ions in the blood.
Yep.
And
they always have to balance.
Exactly, they have to balance.
Yep, so they have to balance. You can't walk around being a positive or negative, otherwise you'd be electrocuting people, or a source of lightning, etc. So if you have a look at it on your blood gas, you've got to add up all the positive ones. Now, most people just leave out potassium because it's only such a small number, 3 to 4 or 3 to 5. Most of it is in the sodium, which is around 135. And then you minus the negative anions that you measure, which is bicarbonate and chloride, and the gap should be around 8 to 16. And so that charge is normally carried on the proteins in your blood, and usually albumin. If that gap is much bigger than expected, then there is probably another anion in the blood which you haven't measured, and so it gives you a clue that there's some other anion around causing this acidosis. The most common being, we'll talk about in a minute, but things like ketones, or people have ingested toxins and poisons like salicylate or methanol. That sort of. So there's a whole range of different things, or sometimes in renal failure if you can't excrete all the sulfates and sulfuric and phosphoric acid. That's a bit of a trick. So high anion gap metabolic acidosis. So you calculate the anion gap, and if the anion gap is over 20 or 30, it's almost certainly there is a high anion gap metabolic acidosis. The most common ones are, which Graeme, you were talking about before, ketoacidosis, lactic acidosis. Uremic, that just means in renal failure, because your kidneys aren't working properly, you're not able to excrete the acids that your body makes every day. And then toxins. We're not going to go through all of these, but these are, you can look this up if you have a patient and you're systematic when you analyse the blood gas and you find that there's a high anion gap, then you can Google and try and find out on the history what's the most likely thing.
Exactly, I remember mnemonic mud piles.
Yep.
And now I have to scratch my head and
there's
think.
Another one called Carmel, which is a bit easier, because mud piles has got some obscure ones in there.
It does.
A Carmel is, I think, ketones. What's A stand for?
Alcohol?
Yep, I think that's right, alcohols.
R
is renal failure. M is... let's skip ahead because I think I've got it in there somewhere.
But they are the causes of a high anion gap metabolic acidosis.
You can Google it.
Yes.
So there's a whole list of them. And the truth is, you're gonna look for a clue in the history or the other electrolytes. So if someone's a known diabetic, you're going to start thinking about the diabetic causes. If they've got known creatinines through the roof, you're going to think about the renal ones.
Yeah.
So what about a normal anion gap metabolic acidosis. That's a bit easier actually.
It is.
So basically there is no unknown anion, it's just the chloride's really high. So that's a known anion, you know the chloride's high, and the most common causes are loss of acid, loss of bicarbonate,
yes.
which can be diarrhea or aspiration of small bowel stomas and things like that, which
Yes.
make a lot of bicarbonate. Renal tubular acidosis, I'm not going to go into details there, but basically your kidneys have trouble with reabsorbing the bicarbonate.
Yes.
And saline is an acid, and so is hydrochloric acid and ammonium chloride. So sometimes people get given those obscure things on the right for therapy, and that's causes an acidosis. All right, so this is the sort of thing you would see. So this is what you would see. So a high anion gap metabolic acidosis is pretty common if you're looking at someone with DKA or lactic acidosis. And hyperchloremic acidosis is someone who has had lots of saline or has renal failure.
And when you say saline,
Or
I mean the
renal
commonest
tubular
cause is a significant volume of what we call normal saline, or 0.9% sodium
That's
chloride
right,
solution
Yep.
as an IV fluid.
Yep. So usually you see that when patients have been resuscitated with a large volume of normal saline.
Yep. Which has about close to 150 millimoles per litre of chloride.
That's right, yeah, because it's basically sodium and chloride. Yeah, 140, 150. I can't remember the exact. So let's have a look at the HAGMA, high anion gap metabolic acidosis, on the left.
Yep. So
Why don't I give Graeme a break?
No.
Should I do this one?
This is good for my brain.
Okay.
The pH is low, so this is an acidemia. The PCO2 is low, which indicates a respiratory alkalosis. The bicarbonate is low, suggesting a metabolic acidosis. And then the base excess, which is calculated, is -10. So again suggesting it's probably a primary metabolic problem. Calculating the anion gap, it's 140 minus 110, 30, which is a high anion gap metabolic acidosis.
Yep, so
and I've calculated that by,
that.
I better do it again, sodium, which is 140, take the sum of the concentration of chloride ions and bicarb ions, which comes to 97 plus 113, 110. So 140 take 110 is 30, and it's outside that normal
So it should be 8 to 16.
range of 8 to
shouldn't it?
16.
So there's
millimoles
something
per
that we
litre.
haven't measured, which is lots of anions.
Another
Probably
anion.
something like ketoacidosis, or if patient's in shock, lactic acidosis.
Yes.
Those are the two commonest things.
Yeah.
I'll do the one on the right. And so same again, pH indicates an acidemia. The CO2 is low, indicating respiratory alkalosis, and the bicarbonate is low, and the base excess is -10. Both of those fit with primary metabolic acidosis occurring. And then we know it's a hyperchloremic acidosis by doing the anion gap calculation, which is the sodium, so 138 minus the bicarb plus the chloride. So the bicarbonate plus the chloride is 130. So 138 minus 130 is 8. So there is no unmeasured anion. That 8 is accounted for by the charge that's normally found on albumin or the other proteins in the blood. So that's just a classic hyperchloremic acidosis.
And that can be caused by all of those causes: renal, gastrointestinal tract, or iatrogenic administration of chloride.
All right, take a breath. So we're on to the last one. This has taken a lot longer than I thought, but it is important to actually explain things, isn't it?
It is.
Otherwise people don't understand. So metabolic alkalosis is basically the opposite of an acidosis. So it's a loss of acid from the body.
Yes.
This is a really interesting one that I learned a bit when I was putting this talk together, because it's something I hadn't completely fully understood. So let's have a look. So the normal things that you notice, so the pH is high, so there's an alkalosis.
Mm-hmm.
The PCO2 is actually high as well, so that's a respiratory acidosis, isn't it?
Yes.
And we'll come back to that, but the primary problem is alkalosis, so that's probably compensatory.
Yes.
The bicarbonate is very high, indicating, and remember bicarbonate is a base, so indicating there is excess base, so it's alkalosis, metabolic alkalosis, and this is confirmed or supported by the base excess, which is positive, i.e. more excess of base is present, indicating a metabolic alkalosis. And we could calculate the anion gap, but that would be if we were thinking about looking for another maybe a metabolic acidosis as well, because you can actually have both. But we're not talking about that today, so we're not going to bother. What are the causes of metabolic alkalosis? This is a bit tricky, so we'll help because I had to learn this as well.
So it's loss of acid from the body.
Yep.
Usually causes the metabolic alkalosis.
Yep. So where does acid can be lost?
So it can be lost from the gastrointestinal tract.
Yep.
So people who have intractable vomiting.
That's right. So the stomach secretes a lot of hydrochloric acid, doesn't it?
It does.
To kill all the bacteria and nasties that we swallow.
Yes.
If you vomit a lot, you lose a lot of hydrochloric acid.
Yep.
So that makes what's left behind is bicarbonate, and you become alkalotic.
Yes. You can lose it from the renal tract.
That's right.
So we often deliberately treat patients with diuretics, and that can be a cause of acid loss from the body.
Yeah. So some of our diuretics, thiazides and furosemide, etc., stop the kidneys from reabsorbing acid properly, and potassium, and so you end up getting alkalosis.
We can also lose acid from the stool in some instances as well.
Yeah. I think the most common, what I didn't really appreciate is that you have to have something to initiate the alkalosis, but then you actually have to have something, we'll talk about that in a second as well, to keep it going. Because the kidneys are actually, so when you become alkalotic, you have high bicarbonate. But all the bicarbonate actually is filtered in the glomerulus.
Yes.
And it's very easy for the kidney to then just not absorb all that bicarbonate back, just to let some of it go and to adjust things very easily. So it's actually very, very easy for the kidneys to adjust for this condition. So there needs to be some sort of abnormal process that stops the kidney from doing that. Anyway, so we've talked about the most common cause of initiation of metabolic alkalosis. It's protracted vomiting, or people who've got nasogastric suction in, as it keeps sucking out all the hydrochloric acid from their stomach, and diuretics. Sometimes people get infusions of bicarbonate or citrate or lactate. So citrate and lactate are metabolized in the liver to bicarbonate. So patients who are on dialysis, or when we give lots of blood transfusions, they're full of citrate as well. And lactate, so Hartmann's solution, acetate, which is in plasma, all of those things are actually bases. Mm-hmm. So they're different to sodium chloride, aren't they, which is, or normal saline, which we infuse, which is an acid. These ones have a base in them. Yes. Anyway, so the maintenance means basically if you have low chloride or low potassium, there are endocrine responses to that which affect the kidney's ability to reabsorb, to excrete the bicarbonate. So I'm not going to go into details, but basically the kidney is trying to trying to retain potassium and chloride, and because of that, because it's reabsorbing all the chloride and the potassium aggressively to try and keep the body normal, it has to let some other anion go, and that is the bicarbonate. So if you're chloride deplete or potassium deplete, the kidney says, right, what's more important? It doesn't actually say that because kidneys can't talk, can they? But basically it has to make a decision. It has to decide what it's going to hang on to and what it's not, and it decides that keeping potassium is more important than keeping acid.
Yes.
So that's why you can't. The kidney can't correct itself. Can't help you correct the alkalosis. So there's an important concept, because that goes on to how you correct the metabolic alkalosis.
Yeah, exactly.
You usually just fix the chloride or the potassium depletion, and then the kidney fix the alkalosis for you. So what's the compensatory mechanism? So you become alkalotic. So I mucked that slide up as well. It says metabolic acidosis. Please ignore that. This is compensation for metabolic alkalosis. So what do you do to try and compensate for that?
I mean, this is every day's ward round in the intensive care unit. So these are patients who are post respiratory support with ventilation, who've been put on diuretics, and they've become metabolic. They have a metabolic alkalosis.
Yep.
And if you don't fix that, they will hyperventilate and go back into respiratory failure.
Exactly right. So what do they do?
So the compensation for a metabolic alkalosis is to decrease their breathing.
That's right. Yeah. So your body says we're too alkalotic. Let's hang on to some acid.
Yes.
So let's not breathe as much, and we'll try and keep some of that CO2 so they hypoventilate, breathe less.
Yep.
And there is an equation to calculate the expected CO2. You can't hyperventilate too much though, can you? Because eventually you become a bit hypoxic, and that will override this mechanism, because oxygen is more important than pH. And this is the equation, so you can see that it's 0.7 times the actual bicarbonate plus 20 plus or minus 5. So you can see there's a wide range of error there. It's huge.
It was always my big concern in paediatrics with the patients who had, in particular, pyloric stenosis, that we needed to correct the metabolic condition before we corrected the surgical problem. Because if you subject these children, these infants, to anaesthesia with the deranged blood gas results, then they do compensate by stopping breathing.
Yep. And so that's an important point. If you've got someone who has a severe metabolic alkalosis, you need to give them oxygen. Usually our pulse oximeter will show that, but if you wonder why are they having problems oxygenating, it's because they're not breathing much. So if you've got capnography on as well, you can see that their respiratory rate might be low. But anyway, so if you correct that, they'll breathe better. So that's just, I think we were going to go through the compensatory rule, but I'm not going to bother because I think we're running out of time. People are going to switch off. So, now of course, we've just made it seem pretty simple. We've just gone through all the primary ones. So, patients don't follow rules, and sometimes they have more than one thing going on. So you might get a diabetic ketoacidosis, and the patient vomits a lot and loses lots of stomach acid and gets a metabolic alkalosis and a metabolic acidosis. Or you might have someone who has problems with their lungs and problems with some metabolic process. So it all gets more complicated. We're not going to go into that today. Just remember the rules though. Well, these aren't the rules. Just make sure you have a system. Always check for life-threatening things, check the oxygenation, and then you can try and puzzle through the pH and acid-base problems. And have a look at the electrolytes and glucose, etc. Basic humour.
I think the key is to remain systematic when looking at blood gases, and then you'll start to be able to pick up those nuances.
Yep. It's just practice really, and you can't remember everything, just look it up. So especially the compensatory rules, when you're sitting down with a blood gas and you're trying to work through it systematically, sometimes you just glance at something and go, let's go, okay, move on. But when you've got a patient, you're not sure what's going on and they're a bit of a conundrum, you need to spend a bit of time, do a bit of type 2 thinking, I think it's called, where you work through everything carefully.
Take your time.
All right, let's stop. We'll come back again in a minute and do the next one.